Ladies and gentlemen, I think we can start on time. Thank you very much for joining. This is a GRF Progress Review linked event, which will focus on evidence for action advancing refugee inclusion in national health systems. I'd like to first acknowledge our co-organizer, Queen Margaret University, and the panel members, Professor Sophie Witter, Mr. Tovin Kaneneka, who is the Commissioner for Refugees of the Republic of Zambia, Dr. Alain Maina, head of the Public Health Unit in UNHCR, Dr. Santino Severoni, the head of the Special Initiative on Health and Migration at WHO, Mr. Mohammad Mahdi Fro, who is online, the health economist at the World Bank, and Louange Kofi, nurse and public health advocate. And also, I would like to thank and greet the participants online. A few housekeeping and describing a bit how this event will go. We'll start with a presentation on the research finding from the UNHCR Queen Margaret Research Program, which is focusing on expanding the evidence based on refugee health inclusion and health systems integration in refugee hosting countries. And after that, we'll have the panel with a question posed to each panelist, about 5 minutes for them to respond, and then we'll have about 30 minutes for questions and comments. In today's session, and with the support of the panelists, we'll explore how access to national systems helps to ensure better protection outcomes and lays the foundation for durable solution. Before going to the panel, just a few words. Today, we have about 117 million people who are forcibly displaced worldwide. 4 out of 5 refugees remains displaced for more than 5 years, often decades. Without access to national health and social protection systems, their vulnerability deepens, while humanitarian resources decline and prospects for durable solutions remain limited, with conditions for voluntary return still out of reach, like for Sudanese refugees. Over 70% of refugees are hosted in low and middle income countries where health systems are often fragile, strained by limited financing, shortage of medicine and staff, and weak infrastructure. For refugees, this means overcrowded facilities, disrupted continuity of care, and barriers to essential services. Parallel humanitarian health systems can be life-saving in the early phase, but unsustainable over time. And they are not nationally owned and often do that host communities also depend on. Protracted displacement requires a development-oriented response anchored in national systems. The Global Compact on Refugees has been pivotal in shifting us towards inclusion in national systems. This is no longer an ambition for the future, it is now the basis for a sustainable response and a prerequisite for durable solutions. However, inclusion of refugees in national systems is not straightforward. More evidence is needed on the rationale for and approaches to achieving better health systems integration and whether these lead to ultimately better health outcomes for refugees and host populations. So this session will share new evidence from 6 country case studies: Kenya, Zambia, Mauritania, Iraq, Peru, and Pakistan, and a global synthesis on refugee inclusion and health systems integration. We will discuss policy trajectories, contextual drivers, and lessons learned, and explore what works for refugee inclusions and resilience. We'll also launch 3 policy briefs prepared by Queen Margaret University and UNHCR to inform policy and practice. And without further ado, I will hand the floor to Professor Vita to brief us on the research finding, and you have 15 minutes, Professor. Over to you.
Thank you very much. Can you hear me all right? Great, thank you so much. So I'm going to move straight in. I think a lot of the background to the work has just been really clearly explained. Our focus was on inclusion, but particularly how to do it and what does it mean for different components of the health system. So this work's been carried out over 3 years, and the 6 case studies were just highlighted by the Commissioner, and we also started with a global literature review. And what I'll be presenting today is the results of that, but also some messages which came out of a meeting which we held on Friday, where we included other research groups working in this area who have got very complementary messages to share. So thank you to all of our colleagues who joined us on Friday. So just to jump straight into some of the findings, as highlighted, one of our questions was around what we call the policy trajectory. So that means how is it and why is it that countries are able to take a kind of inclusive approach to refugees? And we've highlighted here just on this slide some of the factors that came out of the case studies as being significant. Some of them are harder to alter. They're around, for example, the scale, speed, and distribution of refugee arrivals. So smaller inflows, slower arrival, and more even distribution in principle make absorption more easy. But also there are important factors that came out relating to cultural affinity, where population groups were more easily received and absorbed by the host population. Clearly, in the countries, the socioeconomic context also plays a role. Countries that have more fiscal space, that have more resources available for the health system, were able to absorb refugee flows more effectively. But the role of external support and geopolitical factors also came out as a significant factor. So more aligned aid, indeed more development funding. So the switch more from humanitarian to development funding has been influential in how national governments make choices around refugee reception. Legal frameworks, as you would expect, came out as important in a number of countries like Peru, where the rights to documentation and work and again were significant, and these have to be effective in practice and not just in theory, obviously. Political discourse, you'll all be well aware, is very influential, and we have examples in our case studies, both positively and negatively, where that shaped reception. For example, in Kurdistan, the government took a very proactive stance to giving messages which were receptive and emphasized the positive role that refugees could play. In other countries, we've seen more of a downturn in terms of the kind of political discourse. And finally, the strength of the health system itself is a really important, not just to whether they're, for example, if you have more universalist health systems, which are more inclusive already when refugees arrive, you often have mechanisms, risk pooling mechanisms like social health insurance or policies that provide subsidized or free access to care, which enable easier absorption of the refugees. So it influences the choices that are made, but also the outcomes of the inclusion in terms of what kind of quality of service and coverage is available. So these are all factors. Some of them are easier to change and others are more fixed, but they're all important to acknowledge. We then looked across the countries at how the different health system blocks, as they're sometimes talked about, need to change or react, and what's important. And particularly here, we've just drawn out some of the enablers for refugee inclusion. So on the governance side, whether countries adopted a kind of whole of society approach, taking multi-sectoral action, whether refugee policy and planning was built into national policies, but also very helpful where refugees have been included in sectoral governance. So, for example, in Mauritania, in health facility management committees in the areas refugees were included. And in a number of countries, such as Kenya, we saw that decentralization could help in enabling more integrated local planning. So these are just some examples. But from the financing side, as I said, the use of development funding has in some cases been helpful in strengthening public systems that were inclusive of both refugees and local populations. And as I said, the availability of mechanisms such sometimes, for example, performance-based financing was a helpful mechanism to fund services for both communities, free healthcare policies, etc. And in some countries, such as Uganda, we've got some positive examples of where refugees were included in resource allocation formula, such that the local budgets took into account the total population numbers. On the service delivery side, some enablers included kind of work with community actors. For example, in Peru, the work of local civil society was very important in helping refugees to access services to which they were entitled, but also strengthening of components such as supply chain and public financial management systems. It's a work in progress in a number of settings, but it's an element which enables system strengthening as well as refugee inclusion. And finally, some very strong messages coming out around the health workforce. And indeed, I've got an example sitting here on the panel with me of illustrating the importance of including refugee health workers, both for sustaining their skills, for helping communities to have cultural access to services, but also making use of important refugee skills and talent. So these are just some examples of enablers. I mean, in terms of the overall impact for the kind of UHC outcomes, our findings do suggest that the outcomes are very closely linked to the state of the wider health system. So you can have, at least in the short term, in some cases, there can be improvements, there can be deterioration depending on the sort of transitional arrangements. But the overall message, I think, is about the need to strengthen the local health system for sustainable response over time. So in terms of this process, I think what we're highlighting is it's really important to recognize, think through, and kind of manage the trade-offs, particularly thinking about providing a sort of longer-term support so that the burden shifting is mitigated, and recognizing the fact that the transition is going to take time, and these crises, as we've said, are very protracted. Just a final strand on social cohesion, which was one of our questions. When we started out, we looked at the literature, we found that there was very limited evidence specifically of the relationship between health system inclusion and social cohesion. Our findings suggest that it's a very interesting two-way interaction. So social cohesion is both an enabler of inclusion, but also an outcome of it. And that couple of the important mechanisms that came out for supporting social cohesion, one is clearly that there's perceived fairness, so that refugees are not given services which are a higher quality than the local health system, but equally they're not excluded from it. So this issue of a kind of intercommunal fairness, but also very strong evidence around the kind of everyday interactions that happen when you include refugees, which can really increase the kind of trust and mutual knowledge and comfort of the communities. So in some cases, as I mentioned earlier, pre-existing kind of cultural links, kinship links, linguistic ties were very strong enablers. And in other cases, the absence of such ties led to discrimination. But as I said, these are not predetermined relationships. They can be moderated through, political and social discourse. in all cases, the local socioeconomic conditions sort of mediate these relationships. So you can either manage it positively to reduce that sense of competition for resources, or indeed you can allow a kind of negative spiral to occur. So this is where the role of leadership is really crucial. So just to mention some challenges across the settings, obviously we're in a context where aid has been reducing and we have ongoing coordination issues between different agencies and different systems. Many regions, as we highlighted already, have got chronic insecurity. And in a number of countries, the rights to work are limited. This is really drawing from the wider set of contexts we were looking at on Friday, actually. Lack of preparedness was an element that was highlighted by some of our colleagues. So not having plans in advance to how you're going to manage refugees when crises happen. And on the health sector side, we recognise that both host refugee populations have got increasingly complex health needs. Many health systems are very fragmented. There's lots of issues of resistance from professionals to inclusion of the refugee health workforce. And indeed, we're seeing quite a loss of capacity in some of the organisations responding to refugee health needs. So plenty of challenges. I don't think any of these will be unfamiliar to you, but we have to recognise them in terms of the context. But overall, I think the key messages that are coming out, so the first one around is really that while this is a normative trajectory, in other words, this is a direction that the international community is recognised as important for sustaining coverage of refugees in the longer term. It's not a binary variable. So none of these health systems can you say they're either integrated or they're not. It's much more complicated. You've got these different elements within the system, different population groups, and it's a process. It's a process that takes quite a long time to develop, and it can go forwards and backwards. That's the other thing that came out on Friday very clearly from some of the case studies, is that it can also be reversed. So it's a complicated process, and the different elements of health system integration are connected but separate. I think out of our findings, we're saying they're not all the elements are equally important. Some are probably more significant and should be thought of earlier on. So in particular for health financing, we're highlighting that revenue streams potentially can stay separate, but it's very important you start to develop shared risk pools. And that's an element which also can be harder to reverse. So if we're thinking about inclusion reforms, which can sort of stick more, that could be one of them. As I've highlighted, the context is really important, but the context is also amenable to intervention and shaping. So promoting this kind of discourse of inclusion is really crucial. People and personal relationships matter. So out of some of the studies and also the discussion on Friday, it was very clear that sometimes inclusion, and I think this is a quote from one of our colleagues, leverage points to sometimes just the right people talking to the right people. So we should never neglect the role of, inspirational individuals within organizations and institutions that make things happen, and creating those networks of motivated people is also part of our job. We saw some very interesting examples of how global discourse and regional and country level influence each other, and it's not just a one-way story. A lot of the global practice has also reflected what's going on at the country level, so I think that's interesting to highlight. And then, as I said, the arrangement of the health system, how it's set up, is really important, and more universalist health systems are very supportive of inclusion. Finally, just to pay a bit of tribute to organizational flexibility, I think we really saw some good examples in our country studies of how UNHCR was able to change its role in different settings to adapt to the context, sometimes being more interventionist early on, becoming more supportive of the health system, moving into occasional operation, emergency response. So that kind of organizational flexibility really crucial. So final slide, just to highlight some of these enablers that came out of health system, relating to health system integration. So one is the importance of strengthening the system and its subsystems. One is really focusing on supporting domestic prioritization of healthcare, and that includes donor coordination to support risk pooling. One is around decentralization and strengthen leadership, and that includes community engagement and refugee consultation. A fourth one is around refugee health workers. So it's very important that they're enabled to join the local health workforce. As I said earlier, this has multiple benefits for both communities. Fifthly, inclusive policies and language to address stigma and to highlight refugee contributions. And finally, better and more harmonized collection of routine data and its use for decision making, which was an area that was less strong in some of the case studies. So I think those are our key messages. And I just want to thank all of the teams, and also to highlight, we've got 3 briefs sitting over here on the desk, which summarize some of the lessons. So if anyone's interested, please pick up copies at the end. Back to you, Chairman. Thank you.
Excellent. No, thank you very, very much, Professor. So we'll now start the panel. I'll start with Zambia. We've seen or we've heard the key messages from the research presented. What are the perspective of country hosting refugees, and what support is needed at country level to address the challenges of inclusion and ensure that host and refugee communities can benefit from inclusion processes? Commissioner, you have the floor.
Thank you, Assistant High Commissioner. My name is, as it is on the name tag, unless one is insisting that I should pronounce it. But let me leave it at that. Thank you for hosting Zambia, and we are grateful that we will make our case known where we are in terms of inclusion in health. First of all, I want to make mention that Zambia has been hosting refugees, I think, for the past 5 decades, mainly from the DRC, Rwanda, Angola, and of late, I think the numbers increasing are those coming from Burundi. And as these people are forced to move or to migrate, they come with the different challenges. Of course, a wide range of challenges, but mainly for the sake of this meeting, we are looking at the health sector. We continue having challenges in the area of health, in terms of these areas that have been designated to host these our friends, asylum seekers, refugees. These are areas, first of all, that initially were not developed. These are settlements which are coming out of nowhere. They are starting from nowhere. So literally in terms of infrastructure, there's that serious challenge. So as these people arrive, we start from nowhere to start putting up anything that is called infrastructure. With that comes a lot of challenges coming from a developing nation, and the challenges include financing, and even where infrastructure, a little bit of it has been put, we still have challenges to do with the financing. Financing is relatively a big challenge, and also in terms of human resource. I want to make mention that, you see, sometimes in that part of the world where we come from, deploying a qualified medical doctor straight from the university or anywhere, and we are deploying this person in a rural setup, doesn't become an easy thing. You find that most of the people will not be willing to get to these areas. All the same, that does not remove the need for qualified personnel to be in this area. Therefore, what are the needs, the immediate needs that we have in order to service these communities? By the way, there are already people, there are already these people of interest, and these are the refugees that are already in this place. And you agree with me that in the absence of health, I don't think anything moves. For people to go to school, they need to be in good health. For people to engage in any meaningful economic activities, they need to be in good health. So what is it that needs to be done in order to close up these gaps or challenges that I've mentioned? I think we need massive investment, number one. We need massive investment in terms of infrastructure, because what is available, get it from me. If you ask me, I'll tell you that these are more of makeshift, just to cater for the immediate needs as the people arrive. So we need massive investment in terms of infrastructure, in terms of human resource. If you ask me, I'll tell you that there's political will, there's will from government, hence the decision by government to designate these areas to cater or to keep these people. So that will is already there. Also, the little that government has done by deploying a few health workers here and there, that shows the willingness by government, which needs to be taken advantage of. So, all in all, we need massive investment, and this talks across human resource, financing, in terms of infrastructure, supply, consistency in the supply of medicines or drugs, if you like. I submit you.
Thank you. Thank you very much, Commissioner. Very, very clear, very remote location in which refugees arrive, continuous flow of refugees from neighboring countries. Just before we started, you were telling me about the concern you have vis-a-vis the situation in the DRC and the possible arrival of newcomers, and you stressed it, the difficulty to deploy qualified staff to some of these locations. At the end of the day, the importance of financing. Thank you very much. I'm going to move now to UNHCR. Dr. Maina, the research has highlighted potential pathways and policy recommendations for including refugees in national health systems. What are the barriers and opportunities to implement such recommendations? And what is the role that UNHCR can play to help address them? You have the floor.
Thank you, Mr. Rauf. And it's a great pleasure being here. Thank you all for coming, and great to see so many people online as well. I do appreciate speaking after Zambia, who is demonstrating leadership and great example of political will and a collective responsibilities to ensure that countries like Zambia receive the sustained support they need to succeed. As noted earlier, with forced displacement at historic levels, we are facing health challenges that are increasingly complex, protracted, and system-wide. In refugee settings, we're seeing 1 in 10 children are acutely malnourished. Children under 5 account for nearly 1/3 of reported deaths, and there's a marked rise in mental, neurological, and substance use conditions, as well as a growing burden of non-communicable diseases, alongside persistent challenges in ensuring continuity of care for people living with HIV and TB. Amidst all these, refugees continue to encounter legal, cultural, financial, administrative, and geographic barriers compounded by overstretched national systems and exclusion from national policy and financing frameworks, as Sophie highlighted. So closing these gaps is not only essential, it is also important to expand access to healthcare and advance protection by safeguarding refugees' rights, the dignity, safety, and ability to exercise the right to health at par with nationals. So the research together with Queen Margaret University and various other academic partners reinforces the direction set in UNHCR's forthcoming Global Public Health Strategy 2026 to 2030, which marks a deliberate shift away from fragmented parallel humanitarian health delivery toward an integrated, government-led, nationally owned responses that promote equity, sustainability, efficiency, and resilience. So this is fundamentally about sustainable responses, as you've heard us mention many times. And I look at 4 key elements here. inclusive policies and legal frameworks are important. And here we recognize the important role of governments, but also key partners like WHO. And I'm happy to have Dr. Santino here with us on the panel. And we're happy to have contributed to the WHO Global Action Plan on promoting the health of refugees and migrants, which calls for inclusive, system-wide approaches that embed refugees in national health policies, financing, and services. Second is about placing community resilience and self-reliance at the center. When refugees can work and navigate systems, understand entitlements, and participate meaningfully, pressure on service delivery decreases and outcomes improve, and social cohesion is strengthened, as Sophie highlighted. Third, it's also about what we're calling inclusion from the start, where actions we take at the onset of emergencies evolve into nationally led, development-informed responses that can be sustained over time. And lastly, it's about shifting from a default camp-like response to a human settlement approach, enabling displaced people to settle in existing communities while expanding services in an integrated manner through national systems. So many countries have already made tangible progress, and we're seeing, like in Chad, refugee health workers in national refugee health workers have been included in the national workforce. They've already registered around 150 healthcare workers in the National Medical Council, and already about 50% of them have received gainful employment. We had a good discussion with a foundation, World Diabetes Foundation, examples of what we're seeing in Burundi, Tanzania, and Rwanda, where we've seen the partnerships with the foundations having an important catalytic effect towards expanding integrated service delivery models in strengthened national systems well beyond the refugee hosting sites. Refugee inclusion is therefore not a single policy act. It's about an inclusive system transformation. And this is echoed in broader evidence, showing that investing in health is a powerful driver of human capital, economic growth, and job creation. Yet the World Bank's recent report on projections on government health financing highlight growing economic uncertainty, with the governments facing weak growth, high debt, stagnant revenues, and declining development assistance for health. So this makes universal healthcare delivery increasingly challenging. But the evidence is also equally clear that bold reforms in health spending will deliver rapid and tangible returns, improving efficiency, aligning development assistance with national priorities, and undertaking macro fiscal reforms to expand fiscal space. These reforms will save lives, create jobs, accelerate economic growth for both refugees and host communities. In conclusion, the evidence is clear. Humanitarian responses save lives. Integrated and inclusive national systems sustain them. Thank you.
Thank you very much, Dr. Maina. And I would say it goes beyond health. Policies and legal framework. This is absolutely key when one talks about inclusion and sustainable responses. Ensuring that refugees are put in a condition where they can fend for themselves and are not dependent on humanitarian assistance. As you said, starting inclusion from the start. When an emergency starts from the beginning, we have to think about the long term and avoiding situation of camps or developing camps. And this is what we're looking for, not just for health, but also in other sectors. If you allow me, I will now move to Dr. Santino Severoni from WHO. Strengthening national systems is vital for refugee inclusion, as confirmed in this research. What is WHO's guidance on the policies that are needed for strengthening inclusive health systems, particularly in systems with large refugee population? Dr. Santino, you have the floor.
Thank you. Thank you very much for having me here today. And let me start by congratulating UNHCR and Queen Margaret University for this very interesting piece of work. Very important to keep documenting country practices. We are giving a lot of attention to this area. More than give guidance or suggestion, I like to reposition my few thoughts that I'm going to share now on sharing our experience, what really we are observing on the ground, what are the challenges, what works and what not. So the first challenge in order to lead or end up with a health system or health sector which is including refugees is really engage in a very fine discussion with the health sector to build confidence, build ownership of the health sector. What we are observing is certainly a change to compare with a few years ago, but health sector used to be ready to intervene in the case of public health emergency, not really looking at the prospective and the gaining of intervening versus the issue of not action in terms of inclusion of refugees. There is a problem here because the refugee definition, the refugee name, tend to label the topic as an emergency. And this means extra budgetary resources. This means time-limited interventions. This means very often not capacity building because who deals with emergency sometimes is not the health sector, but is the civil protection or other area of the government. So it's very, very important to build this confidence and clarity on the role that the health sector must to have in managing the health issues related to refugees. And I cannot be pessimistic because actually, if I'm looking back to the last 10 years of work with the member states, first of all, what we learned that is needed almost one-to-one interaction with countries. You cannot go with stereotypes or one-size shirt for everybody or in formula which are, magic solving issue. No, you need to engage almost one-to-one with each country, understanding the context, translating global priority experiences from other countries and try to embed them into the national context of the country, which is going to move towards including refugees. And what we see today, a big shift, because a few years ago, health sector was rejecting interaction from WHO, saying, but this is not a health issue. And now we mapping about 90 countries worldwide, so almost half of our member states, which they're having clear policies. Actually, we are monitoring the changes at country level using the building block of the health system. So we see at least half of the countries which are proactively engaging into modernizing and reforming the health system in order to play an inclusive role. During the previous intervention, I'm sorry if I'm simplifying, I heard a lot of work around leadership in high-level advocacy, important in order to move towards an inclusive health system. This is absolutely true, but the first step is to really build strong ministerial commitment. The question here is, can we stimulate that? Can we encourage, can we change the approach? My answer is yes. Even with countries where the political landscape is negative, conservative towards inclusion, in reality, if we anchor our action to evidence-informed type of action, we have a quite interesting strategic space to move things also with a resistant government. But then we need a clear policy. What we see still today, and this requires a lot of monitoring effort, that policy tend to be generic. We are still committing, in my view, this is my personal view, the mistake to call refugees vulnerable people. So if we are not specific when we are designing policies, we are clearly indicating to whom we want to reach out, policy doesn't function. So we need to have sound policies supported by strong evidence, and we need to be very clear on what we want to do. Then the intersectorial collaboration. The topic is not an health issue only, but health has an important role. We have seen this during COVID, how spill out from other sectors can heavily impact the health sector and vice versa. And then really aligning national policy with local situations. Very often we have a beautiful national policy, but then we don't follow that at the implementation at the local level. We see government deciding to have a very universalistic approach, but then the implementation at the region, at the local level doesn't happen. And to complete the economic dimension, really, we need to invest more energy, more resources to document the advantage or the cost of actions versus cost of non-action. In reality, we need to be clear that including refugees into the health system is an investment at the first step. But then we need to document what is the cost of non-acting versus the cost of acting. And probably we need to start to look to some innovation. We have health system which is structured like that since ever, looking at an health system which is only acting inside the national border. Probably is a time to start to look to innovative situations where we have cosmopolitan health system, where we start to build up conditions where we are sharing human resources, financial resources, services across border. But this needs to be supported by investment, by availability of resources to do that. And today, this is the critical part, because we have a political trend towards nationalism rather than inter-country collaboration. Thank you.
Thank you very much, Dr. Santino. Building confidence, I think the event that we are organizing today is part of that. You're right in saying that often refugees are seen, as soon as you see refugees, see an emergency, but not the long term, not people who are economically integrated. And you're right in saying that policies, clear policies are essential. Your last point on documenting the advantages and the interest for governments to include and integrate is also essential. And this is something that we're looking at in all sectors, in health, but also in other sectors. What we're saying is that ensuring that refugees become self-reliant and integrating them rather than have parallel services, generally speaking, is better for government. We are documenting that with colleagues from the World Bank and other institutions, and we'll continue to do that. Precisely now moving to our colleague from the World Bank, Mohamed Mahdi Fro. What are the costs and the benefits of refugee inclusion in national health systems in the short and long term? Based on the World Bank UNHCR study, what role does the World Bank envisage playing in supporting country health systems seeking to include refugees? You have the floor.
Thank you, Chairman, and good morning, everyone. Let me reflect upon the question into three different parts. First, on the cost of inclusion. As many colleagues on the panel have spoken about, that inclusion is the pathway, and the World Bank very much agrees with that. And I think last year, the World Bank and UNHCR did the global costing of refugee health inclusion. And this is a concern for most of the hosting countries, that is the cost feasible for them? Is it fiscally sustainable for these countries? And I think as we break down, the cost of inclusion by different income group, and for majority of the countries which are low-income countries and fragile states, the cost of inclusion is very modest and it's very manageable. And we are even if in all of the low-income countries, if we pursue inclusion, the cost is something in the range of between $200 to $300 million annually. But obviously, if you pick countries with just with the high number of refugees, the cost is even lower. So there's evidence in the work that we did jointly with UNHCR suggests that, this is not a huge amount of costing that we are going to talk. Especially these numbers make much more sense when you compare them with humanitarian way of delivery, where you also have the costs of duplication of efforts, costs of parallel system. There is a huge overhead cost and all of that. If you compare, this is way more, cheaper than that. But also, as our colleague from WHO on the panel mentioned, when you want to compare this with the cost of no action or non-provision of health services to the refugees, I think the benefit outweighs way more, just because if you are excluding refugees from the national health system, and if there is no service delivery through the humanitarian mechanism, the cost of accessing healthcare out of pocket, it moves to refugees. Refugees has to incur a lot of out-of-pocket expenditure, which leads to a lot of equity and poverty issues for refugees. But also, there is all sort of implication for the health system around, public health risks, and there's going to be disease outbreaks among the refugee communities. The care is going to be delayed. There's going to be a surge on emergency care at the hospital. So a lot of missed opportunity of preventing avoidable hospitalization. So if you want to compare the cost of inclusion versus, delivery versus humanitarian or versus no action, you can clearly see that this is the most sustainable path to take there. Now, with that, let me transition to the second part of my remarks, which is around the benefits of the inclusion. And I want to talk about this in two different phases. On the short term, obviously, the moment you include refugees, and it's obviously there is a work around across the building blocks of the health system. It protects refugee access to the essential health services, but also it also improves the disease surveillance systems in the country and avoids many of the outbreaks that's going to happen in the country. And it's also going to benefit not only the refugees, but also the host communities. And there was a lot of discussion around social cohesion here. But in the medium to long term, as we look into this, it strengthens the core of the health system, because because of the fact that you're using the country system, it helps the financing, service delivery, the health workforce, even the health information systems in the country, and it builds all of that evidence that we need, the visibility that we need around the refugee population. So it also going to reduce significantly fragmentation, inefficiencies in how aid is being delivered and how services are being managed at the country level. It supports social cohesion. It shifts the mindset, but also the financing and planning from one of the emergency response to more a predictable and development-oriented financing, which the countries can take the ownership of delivering services. So as a total, it's a high return investment, including refugees into the national system, just because having a healthier refugee population means they are being more productive, less dependent, and in the long term, it's going to benefit that, they could be able to pay, for example, if there is an insurance, they could pay their premiums, or they could contribute to the national pool through taxes, and then eventually there is no need for external aid. With that, let me turn to the last part of my remark, which is about where the World Bank sees its role. As we are facing this unprecedented time around critical contractions and the humanitarian aid for the refugee health. I think it's not something new, but the World Bank really contributes through three different ways. On the first one, let me highlight that it's not that the World Bank has started now, but I think it's been there for a couple of years. There is always a question, where does the financing comes from? But under our IDA, we have a window for low-income countries, the window for host communities and refugees. And this window provides financing to the host countries to support the refugee inclusion. And I think countries should make use of this window, and there is financing available for that. And similarly, we have a window for middle-income countries to support the refugee inclusion and to the national health system. And then obviously, along with our financing, we do a lot of analytical and technical support, as the chairman mentioned and Dr. Maino mentioned. Last year, we did the global costing of refugee health inclusion, and at the same time, we are working, on really building on what Dr. Sophie presented around what it means, what inclusion means. Really, I think the next practical step that we would like to take jointly with our UNICEF colleagues to sort of look operationally, what does it mean, even the transition or even inclusion of the refugees at the country level, given the variety of contexts and the health systems there. And also, we have many local offices and many country-based offices, which already supports many of these countries with the health system building. So I think we can use of their expertise there as well. And lastly, on policy dialogue also, and I think the World Bank is very much aligned with our key partners, and we recognize the country leadership for all of this to make this happen. So let me close my remark by saying that the inclusion is not cost-free. Obviously, there is cost, but the evidence is clear that it's much more affordable than the alternatives. It's much more sustainable than the parallels, and the benefit significantly outweighs the cost. And there are financing available that countries must use. With that, let me turn it back to you, Chairman. Thank you.
Inclusion, as you said, is modest and manageable, and you actually gave figures about that. You also stressed the fact that refugees often find themselves having to pay out of pocket, and that increases the level of poverty. And you, when talking about the benefit of inclusion, you said that there is, of course, we can avoid the outbreak of illnesses if you make sure that you include everybody, and that's for the interest of the host population. Lastly, there is the issue of the contraction of aid that we're all aware of, which is very, very serious. But you also underline that there are some resources that are available, windows for middle-income countries and for low-income countries. So thank you very much for your points. I'll now go to our last speaker, Louange Kofi, a nurse and health advocate. You've heard from government representative, academia, UN development partners. The research presented today highlights that the health system integration process does not only concern the integration of system, but also the inclusion of people, of the refugees themselves. So what are your thoughts about what you've heard? You have the floor.
Okay. Can you hear me loud enough? I think I want to do without the mic, or maybe. Yes. Okay. Yeah. So basically, I've heard all the enablers. I've heard some of the solutions. Before I say much about that again, I want to tell you a very short story about me. I don't like speaking without telling a story. So my name is Louange, and I grew up in a refugee camp. I was born in the camp, and growing up, I realized that I was always in and out of the hospital, either on admission for a disease or something, an infection. And upon all those multiple admissions, one really struck me, and I was there for a week. And prior to that, I had very bad experience at the hospital just because I am a refugee. The treatment was different, and one really stuck with me, and that's made me become a nurse today, and I'm currently pursuing my master's in public health. Yeah, so why am I saying that? I wanted to be a journalist. I loved telling stories, but I changed. I wanted to become a nurse because of the things I saw around me, how refugees were treated when they sought healthcare. Okay, moving away from that. Yes, I'm here right now. Going into the Ghanaian nursing training system, I would say it was a privilege. And this is what we are speaking in the room today, that we should include refugees in the system. It's not only when they want to have access to healthcare. No, because they have the skills to also deliver healthcare services. I'm a proof. I've worked in the Ghanaian system. I have my nursing PIN registration. I have legal documents that permit me to work in Ghana as a nurse. And that's what has brought me here today. Now, let me talk about some of the programs I've had. And it doesn't just benefit the refugee community. I have an NGO where we got funding to organize health programs in the camp. And I didn't just stop there. I went into the host community. So it means that when refugees are included in the health system, there are benefits for the host community too, not just refugees. I don't want to dwell much on that due to time. I want to talk about my journey. It wasn't really easy. I also saw discrimination. Sometimes funding was an issue. But you see, some of the enablers is that some of the programs are already, no, those are the problems, the challenges. The programs are already designed, and refugees just get to a point where they come to the table and, okay, they make it seem like, okay, we are bringing solutions, or we are part of the process, but no, it doesn't really happen. We see it as tokenistic approach, where you see that, okay, we had 2 refugees on the table, but I think that there has been a huge shift in that aspect, where I think 2 months ago, I had a document, not just me, a couple of refugees. We had to review some policies, give our inputs, what we think refugees really need, because I grew up in the camp. I've seen their challenges. So I think there's a step towards the right direction, but there's much that we can do. And so I've mentioned the challenge and I've given you the solutions. I hope we are taking note. Another part I want to talk about is the legal and regulatory constraints. If Ghana had not given me documents to be able to go to nursing training, I'm not sure I would be in this room today advocating for all the refugees in the world. So that is the very first step we need to speak about. Are refugees able to have access to legal documents, to be able to enter the training schools, to become nurses? And what about those refugees who already came into the countries with their documents? How do we make sure that we translate those documents to meet the requirements of the country? so that they are included in the hospitals or the health system to be able to deliver their skills. Refugees are often seen as burden. We are always taken away, but no, we have a lot to deliver. So if you make this possible for us, I think there's a lot that we can offer. And the last one is the fragmentation in humanitarian sector. I feel like some of the goals are not aligned. So an NGO has a plan, but does it align with the national system? What is their, okay, they are focused on universal health care, but what is their focus? We really need to align our programs to theirs. And I heard that we need constant follow-ups. It's not just a one-time meeting. Okay, we need you to include our refugees in your system. No, you really need to follow up, maybe in the year, constant meetings, reminder, because they have a lot to cover. So if we keep pushing, I think we can have a push or something to make a change. Yeah, so right now, I'm not in Ghana, right? I'm in France. And I'm coming to acquire a lot of knowledge to be able to send back to the country. I'm advocating on behalf of every refugee here that please create chances for them. Always include them, bring them at the table. In cases of policies, decision making, please bring them research, include refugees. And I think we are going to do a lot. Thank you so much. Yeah.
Thank you very much, Louange. Not only did we take notes, but we also clapped. You were the only speaker for whom we clapped. But hearing your points. First, your story, very important. Why did you become a nurse? Because you experienced what it meant to be a refugee and be treated differently from the others because you were a refugee. You also underlined the fact that it was a privilege for you to enter the Ghanaian nursing system. It shouldn't be a privilege, should possibly be a right for refugees who have the qualification to apply. You were also strong on saying that once you have been given that opportunity, it's also a benefit for the entire community. You underlined the fact that the participation of refugees should not be just tokenistic, but actually regular and structured, and the importance of documents. And I would say that's broad, that's for all services. And you also made reference to the fact that those who come to a country as refugees with documents with qualification, these qualifications should be recognized. So thanks a lot for what you said, and I hope that what we said you find it also useful. We have about 15 minutes because unfortunately we have to close by 20 or so. I'll now open the floor for comments, questions, and then we'll come back to Professor Witter to conclude what you've heard and also in relation to your research. I'll start with Morocco and then I'll go to IOM. Morocco, you have the floor.
Thank you very much. Au lendemain de sa participation active au pledge multi-acteurs visant à promouvoir l'accès des réfugiés au système de santé, aux systèmes nationaux de protection sociale, le Maroc poursuit ses efforts pour renforcer l'accès des réfugiés aux différents services de santé.
On vient de me nommer traducteur.
Ok. Sinon, j'aurais préparé mon... Ok. Donc, en fait, au lendemain de la participation du Maroc au forum en 2023, à deuxième session, et spécifiquement au pledge multi-acteurs visant à promouvoir l'accès des réfugiés aux systèmes nationaux de santé et de protection sociale, le Maroc poursuit ses efforts pour renforcer l'accès des réfugiés aux différents services de santé, aux allocations familiales et aux pensions de retraite. Les réfugiés et les migrants ont effectivement accès aux programmes de santé publique. Donc aujourd'hui, ils ont accès à la vaccination, à la santé, donc aux services de santé mentale, santé reproductive, etc. Entre 2022 et 2024, il vous est...
I'm taking notes.
Ok. Donc entre 2022 et 2024, les indicateurs de couverture par les services de santé au profit des réfugiés ont enregistré une nette amélioration. Le nombre des consultations médicales et des prestations vaccinales a triplé. Aujourd'hui, les enfants des réfugiés et des migrants ont systématiquement, ou sont systématiquement intégrés dans les campagnes vaccinales. Le ministère de la Santé continue d'organiser des sessions de sensibilisation et de formation au profit des réfugiés et du personnel de santé. Le partenariat avec le secteur privé visant à améliorer l'accès des réfugiés aux soins continue de se renforcer. Sur le plan législatif, les lois marocaines relatives au régime de sécurité sociale, à l'assurance maladie obligatoire et à la réparation des accidents de travail ne limitent pas la couverture sociale aux nationaux, mais l'étend à l'ensemble des travailleurs étrangers, dont les réfugiés. Enfin, le Maroc mène des campagnes de sensibilisation, d'information et d'accompagnement des réfugiés en mettant à profit les réfugiés eux-mêmes et les ONG, auprès des administrations pour l'inscription dans le registre national unifié et dans le registre social unifié. Voilà. On a voulu être bref.
I'll be very short in translating some of the elements. So the main point is where Morocco is standing after the 2023 forum and our pledge on health. And I thank Maina for that. We've been very active with the UNHR, but also WHO. But locally in Morocco, we've done quite a lot since then because we've committed to cover universal health coverage for all refugees. Based on that, today we're proud to announce that all refugees are covered, all of them, by universal health care. The number of vaccination of refugees tripled. The number of medical consultation tripled as well. They're part of the vaccination campaigns. We are also training health professionals, Moroccans, but also, as you were indicating, on how to be the most efficient refugees who are working in the health system. We're partnering with NGOs to help us, achieve universal healthcare, but also access to refugee communities, along with host communities. And finally, on the labor side, insurance includes refugees now for free as well. So this is a big move, something that we didn't have before. And to finish with it, the advocacy campaign is still ongoing, and it includes refugees. And we're also very proud that we're going forward. And the basic services now today, I think we still need to work a bit on the labor integration, but that's something we're working on. But at least on health services, we're happy to share this good news. Thank you.
Excellent. Thank you very much. And we'll go to IOM.
Yeah, thank you. I just have a comment or like a few questions for the panel as well, and kind of builds up on the comment from our colleagues from Morocco that they not only mention services to refugees, but also to migrants. And as representing the International Organization for Migration, I have two sessions or like two parts of this question. The one mostly is for Professor Witter, like according to the examples of the case studies that you presented, maybe if there are specific actions, elements that can be replicated and possibly upscaled, like low-hanging fruits that can also include migrants aside from refugees, because of course, when we talk about people on the move, there are not only refugees, but there are a lot of different kind of populations. So it would be interesting to see how we can also integrate them when making this kind of conversation. And the second point, which is more for the broader panel, it's how do we also try to advocate not only for refugees, but for all the people in the move. We're been talking about making inclusive policies, but what can we actually do as an international community, especially in a situation where we are right now, to fight for the advocacy and try to really make a universal health coverage universal, in fact, and especially linking with the comment from Ms. Louange, how can we also include the voice of the people of the move, of the migrants and the refugees when doing this kind of advocacy? And yeah, so these are just the two questions and comments I have for you. Thank you.
Excellent point. Thank you. Let me check around if there are. Let me start there, the lady, and then we'll come to you. Please.
My name is Olivia. My name is Olivia, and I'm based in South Africa. I just wanted to ask, so often national or state statistics exclude refugees and asylum seekers, right? And this is not only on health, but also other aspects, economic development and so forth. And so what tends to happen is that some of us who have organizations, RLOs, right? We formulate programs or interventions that are not data informed. And so I would recommend that UNHCR finds a way to facilitate a conversation with the national states so that they can actually release data focused on refugees so that we can be able to see the right interventions to implement within our organizations. But also, you know, complex countries such as South Africa, where issues of migrants and refugees can be, you know, can be hard to put on the table, especially when there is xenophobia involved and so forth. And so if we have data, we are able to actually put something on the table with evidence focus. So if you can assist us with that, that would be helpful. Thank you.
Thank you very much. Good point. Yeah, you have the floor.
Thank you very much. I'm Goodson Sinyenga from Zambia. Just to assure my sister that many countries that are host to refugees are doing their best in ensuring that they extend health provision to refugees as well. In Zambia, we've done that in the area of education, as well as the health policy is extended to the welfare of refugees. Right now, we are trying our best to include refugees on the National Health Insurance Scheme, with over 500 refugees already in the scheme. We've been providing health facilities in all the refugees containment using government resources. Recently, the government recruited health personnel as well as teachers with direct allocation to refugees camps. So you can see that governments are doing their best in providing services to the refugees in the face of reduction, serious reduction in budget support when it comes to provision of education as well as health services. Our policy aims to achieve what we call the universal health coverage, and that extends to refugees or persons of concern as well. And Zambia is a unique country. Most of the refugees, once they come, even when their status ceases as refugees, they don't want to go back to their countries of origin because of the quality of services that we provide. We are grateful to the World Bank. Right now, they are trying to support us with about $30 million to improve the conditions and surroundings of the refugee hosting communities in one of the camps, the biggest camp in the country, maybe even in the southern Africa, called Maheba. It's almost the size of Singapore. So World Bank has come on board, and of course, for the World Bank to come, there are trigger points. Government has to take, for instance, electricity in the area, and government has to guarantee that they will provide necessary personnel to manage the health facilities that will be constructed, as well as schools in those containments. So I thought I should speak to that and assure you that governments started bringing on the table refugees to hear from them in terms of what they want to see in their areas where they live in. Thank you.
Thank you very much. Very encouraging statement. I'll come back to the panel for some of reaction. Start with Dr. Santino, and then I'll go to the commissioner. Dr. Santino.
Thank you, Rolf. Well, the colleague from IOM, indeed, is important to speak about both, but we need also to remind to ourselves that especially when we are entering into the area of health financing and sector reform, we need to be very specific. Ministry of Health, in order to define who is the list of underprivileged part of the population, is very specific, and there are criteria to identify them. So the element of legal framework could be a very important element that it's differentiating the applicability to refugees and migrants. Say that one, we are all agreed that there are very good experiences that can be used across the two group of population, but there is a reality that we need to confront with. In the case of labor migrants, for example, it's actually easier than for refugees to include them into the health system because they're contributing on the financial scheme that generating the health insurance. So said that one, I support that the both groups are important. We can share experience across the both groups, but we need to be very specific. The colleague from South Africa, I fully agree with you. Country is supposed to do a little bit more for data and evidence. I have a good news. South Africa just approved to launch a national research agenda with us, exactly to look into the health sector reform in order to expand the access for refugees and migrants, especially vis-a-vis the secondary care, because primary care is granted to everybody, but then since there is a fee for service when you move towards the secondary care, that's actually is a very physical, important barrier. The movement, South Africa was a revelation because really is the least country we could expect such movement anti-migrants, anti-foreigners. But for what I see, for the commitment of the government, I think that those are phenomena which need to be handled. They are not really determining change of the government, at least in this stage. And the issue of data is paramount because data, it's not that there are no data, but data are collected by different entities into the country. So it's important that countries may be able in the health sector to set target indicator for them to see how things are changing. Again, it's very encouraging the situation because we are just finalizing the next world report. We are going out in February, and for the first time, Ministry of Health supplied very detailed data on very detailed questionnaires on where we stand in terms of inclusion of migrants and refugees into the health sector. Thank you.
Thank you, Doctor. So I'll go to the Commissioner, and then I will go to Mohammed, and then I'll go to Maina. Commissioner.
Thank you so much, Moderator. You agree with me that managing the health sector is very, very expensive. It's quite costly. I can imagine bringing in inclusion. What does it become? But I'll tell you that it will be more expensive to manage a population that is unhealthy. It will be more expensive. The earlier we begin to look at long-term investment in inclusion in the health sector, particularly in the settlements where the most vulnerable people who cannot afford even to buy the most basic medication in an event they are unwell. The earlier we begin to do that, we are preventing a bigger problem in the nearest future. Mind you, as we manage the people of concerns, particularly those in the settlements, if there are any communicable diseases, what happens to the host community? What happens to the host community? It means the problem even becomes bigger than what we would want to prevent, to invest in the name of saving. So where health is concerned, especially where the refugees are concerned, there is no saving if you want to save. What you avoid pushing in today, you might push in double tomorrow if nothing is done. I submit.
Thank you very much. Excellent point. Mohammed Mahdi, you have the floor.
Thank you, Chairman. So just 2 quick points. I think very encouraging comments from our colleague from Zambia. And I think it's going to be an excellent opportunity for all of us, the government, but also for the partners to learn from Zambia and study that case and sort of build the knowledge for applying it to other settings and countries as well. There's a comment in the Q&A in the chat that I want to reflect upon. I think what I would like to say is that to date, that WHO financing that has been allocated to many countries, and you're right, there could be instances and cases where the resource has been allocated to the country, but they may have been spent, for example, on broader health system or on broader education system, rather being specifically targeted to refugees. But I do want to acknowledge that this transition there in the mindset, but also in sort of understanding how this is going to be implemented practically, from humanitarian, this shift from humanitarian to more of a development oriented, from having a separate system to more of an inclusive system, requires a lot of work to change the mindset, to change, to develop all of the manuals and everything. And I think the World Bank, along with its partners, the UNHCR, we are working together to sort of think this through a little bit more, and to build some of these preconditions and into the financing as well. That as we learn more about this context, and we have the know-hows and we have the operation manuals, and we see an opening in country spaces, that moving forward, when resources are being allocated to refugee country, to countries for inclusive system, be it education, be it health, or other sectors, that they are indeed being targeted for the refugee communities. So just to acknowledge that it's a learning process. It's we're still managing the transition, but obviously, hopefully, this is obviously the focus for all of us as well. Back to you, Chairman.
Thank you very much, Mohamed. I'll go to Dr. Maina, then Louange, and then we'll go to Professor Witte.
Thanks a lot. We remiss if I didn't acknowledge the great efforts of Zambia and Morocco, and particularly Morocco, because you hosted the global consultation on the health of refugees and migrants, and there was a Rabat declaration there. Rauf and I were there, and now we're midway to the GRF progress review, and you're already reporting excellent progress towards including all refugees in the national health protection system. Social protection system, and also for Zambia as well. These are great examples, and we have more examples also in the online report, showing out of the 15 targeted countries, 12 of them already reporting substantive progress. So this is a good example of where we're going. I do acknowledge the point that we need to look at all people in terms of universal health coverage, as IOM has noted, both refugees and migrants, and I noted the WHO Global Action Plan on promoting the health of refugees and migrants, which has also informed our policies. But we're also discussing a route-based approach as UNHCR and IOM, where we need to look at people from the country of origin, and also in transit countries and destination countries, and ensuring they access services at par with nationals. So totally agree that we need to do a lot on that. On the data point, last point is totally agree. We have some work we're doing with World Bank with Joint Data Center that is looking at being able to support governments in national statistics and and disaggregating data. But also as UNHCR, we're also working to transform our health information system to nationally aligned systems. And then Santino noted the report that is coming, and we're happy that IOM and UNHCR have contributed to that global report that countries have been able to showcase what they're doing specifically. So there's a lot going on there. There's more to be done, but thank you for the comments.
Thank you very much, Maina. Louange.
Thank you so much, everyone, for the work you are doing already. We really appreciate that, and I want to ask that you continue the good work and to invest in the to ensure the inclusion of refugees in national systems. And before I go, I have one ask, that the next time we meet here, we should see a significant shift or a change, if not totally, but let's see a shift in what we are advocating for. Yeah, so thank you so much.
Thank you very much. And Professor Witte, you will conclude the entire meeting. So
briefly, yes, because I know we're short of time. So, well, just thanks to everyone. Just one question to me, I think, was around the inclusion of migrants. And I don't want to add to what the panel has said, but just to say we had the privilege of working with the health and migration team in WHO recently on a report on an evidence review on health financing for refugees and displaced populations and migrants. And I hope that will be coming out shortly, because it has some really good examples of how different countries have included and addressed some of the barriers for access for labour migrants, for example, which is a huge important category. So yes, I think just to wrap up then, I mean, what I'm hearing overall from the panel is really this, right, one point is around the value of inclusion. So we've heard a kind of cost-benefit analysis with the World Bank data that says it makes sense economically, if you like, in terms, hard terms, to include refugees. And I think by argument, it applies also for migrants into health systems. It costs a lot less than not including them. I think that's valid from a health system point of view, but we've also heard it from a sort of societal point of view, the contribution they have to make, and Luange has made that case very powerfully. Also from a professional point of view and a personal point of view, the value that refugees can bring into a system. So that's one strand, is the kind of argumentation, but then there's also the question of how to do it, and we recognise that policies are not enough, that what really happens on the ground and at the local system level is really crucial. So I think what we've heard about is the need for long-term support for that, real partnership, and all the different organisations here in the room and also online are contributing in different ways, and we recognise that. And then I think the final element is around evidence. We still have areas where we don't know, we're not granular enough in our advice on how to do things. So I think there's still a role to get better evidence, and that's both personal and kind of data-driven. Yeah, so I think just from my side, final big thanks. It's been a privilege to contribute and work with UNHCR colleagues, really recognise their contribution in very hard times. So thank you. Back to you, Chairman.
Thank you very much. Thanks a lot to you, Professor Witte, to Commissioner Kaneneka, to Dr. Maina, to Dr. Santino Severoni, to Mohammed Mahdi, who is calling from Washington, I think. So we can imagine that he's committed, because time in Washington, he is extremely. So thanks a lot for that. And thanks a lot also to Luange for being here and for keeping us accountable. Yeah. Thank you very much. Thanks to all of you. Thanks for your participation.
Thank you.
Thank you all.